Okay, so welcome to our evening PG sessions. Good to be here. And so today we'll just be dealing with, I've just kept as hyponatremia as a part of sodium disorders. And we'll just try to go through this. I'm sure this is something that you've been seeing managing, and you would be having certain concepts. We'll just run through it and try to see how we understand it, how we approach it. Right at the onset, one just to put it in perspective that sodium is not something that a person presents with. It's something that you detect as a part of the patient's evaluations, care, and management. And so it's not about managing the sodium per se, but it's all about managing the patient in its holistic way. And also because it's very critical how we manage the sodium, because if you don't do it well, you can cause more damage. If you don't treat it, there's a problem. If you treat it not appropriately, there's a problem. So sodium really presents very critically, and so to understand that, so here you are trying to understand sodium, you are also trying to understand the setting in which the sodium disorders are, and you have to manage both of them. Acutely, you may have to manage the sodium, but chronically, you have to manage whatever the underlying condition that has led to the sodium disorders. So, just putting on some very basics, we all know the normal values of sodium 135 to 145. Hypo, again, there's a classification will be coming into mild, moderate, and hyper. Just have to remember some values. When we call it as severe is one when it is less than 120, and below 135, we are calling it as hyponatremia. The sodium daily requirement as per WHO is about 5 grams of salt. Just have to remember that is equals to 2000 milliequivalent of sodium, which is equal to about 100 milliequivalent. 2000 milligrams of sodium, which is 100 milliequivalent, and 5 grams, we know it's about 1 teaspoonful. So this is just to help us understand the difference in the electrolytes in the intracellular compartment as compared to the extracellular compartment. And you say in the intracellular, you see the sodium is just about 8 millimoles, whereas potassium is 151. It kind of completely reverses when it comes out of the intracellular. In the extracellular, you see sodium is 140, whereas potassium is reduced to 4. It's almost like an exchange. And here you just need to see that the plasma or the extracellular fluid, plasma is 1/4 of the extracellular fluid. So the larger space is by the intracellular fluid, and in the extracellular, so that's 2/3, 1/3. And in the extracellular, you see the plasma is a very small compartment. It's about 1/4 of the extracellular fluid, and the electrolytes are about the same in both the plasma and in the interstitial fluid. So this is something to put us into perspective. One of the things that we need to understand is whatever you are measuring in the plasma is not really a reflection of the total sodium content in the body, right? So it is in the plasma space, it is at that concentration, but it nowhere represent what is the total sodium content in the body. So that's something to be remembered. And then also to remember that these molecules move across the semi-permeable membrane, and a lot of disturbances are because of how much of that molecules are in that particular space at that point of time. So it doesn't in no way represents what is the total amount of sodium or electrolytes in the body. Also, these are again just the movements that we look into it. One of the important thing over here is to remember two things. One is the antidiuretic hormone from your posterior pituitary gland, and as the name suggests, antidiuretic, that means it is reabsorbing water over here. And there are two things that is really working is the ADH and the RAS. These are the two hormones that is involved in two things. One is controlling the volume, and the electrolytes, right? So just have to understand that sodium is what is driving the volume. So wherever the sodium goes, it takes the water alongside with it. And so regulating the sodium will regulate the volume. And all these are very closely kind of connected in terms of balancing. And so right from the taste of your food and the salt that you take is determining the plasma volume, and is also determining your the tone of your vascular muscles, which will lead to various diseases. So here we are talking about salt related to the fluid, related to the vasospasm, which is related to hypertension. So all those things are in a way connected. So everything is very intricately connected. So just to keep all those things in mind, and it becomes more and more complex in a disease conditions where the number of things will be working. So slowly you'll have to kind of identify each of those pictures and the loops, and how in a complex situations all these loops will work, and how your intervention can also affect either positively or adversely to the homeostatic state. So this is just to show how hypothalamus is impacted by our osmolality about your decreased atrial receptor. So there's a volume, there's the tone of the electrolytes up over there. Those are the two things, including various hormones and the state of the vascular tone. Everything is affecting hypothalamus. In response to that, hypothalamus through the posterior pituitary is secreting your vasopressin, and vasopressin is V1, V2, one acting on the blood vessels, causing increased systemic vascular resistance, and V2, which is involved in the plasma volume. So you have the volume on one side, you have the tone of the vascular muscles over there. All those are maintaining an appropriate amount of pressure in the arterial system, and that is very important to ensure that the blood reaches every cell. Right? So this is again, so keeping all those things in mind, we'll be diving deep into our today's topic. So vasopressin is a peptide hormone formed in the hypothalamus, transported via the axons, secreted from the posterior pituitary. And as we saw, V1 and V2 receptors are what is controlling both the volume and the vascular tone. So the other component in our management of sodium disorders are the volume status, which we keep talking about. And so just have to remember that in the mind, that how do we assess the volume status in our patients from the examination findings and some of the investigations findings. So signs of hypovolemia being poor skin turgor. Again, you have to remember you are dealing with adult patients, unlike children where these things are very important. In adults, you have to put more than just the skin turgor to assess the volume status. You have to look into everything from skin turgor to mucous membranes. Mucous membranes, if a person is breathing by mouth, it will look dry, and that you should not interpret that as dehydrations. So again, turgor, skin, the dryness of the skins, all those things are something that you have to very carefully interpret. The most important things will be the neck veins, your blood pressures, and some of the blood parameters which suggest whether a person is volume depleted, where there'll be hemoconcentrations, or it will be diluted form. So those are some things just to keep it in mind, that as a part of our approach to sodium, the volume status and the clinical and the blood investigations for that is the other thing that you have to keep it in mind. So we'll focus on hyponatremia. So right in the beginning, when you see a patient and the blood test shows hyponatremia, what should be the first thing that should come into your mind? So we have two objectives. First is to identify or categorize the hyponatremia in what type of hyponatremia. And following that, we are looking at the causes. So causes will follow the type of hyponatremia. So keeping those two things in mind, we will be looking into the type of hyponatremia. The first step is to say whether the person really has a true hyponatremia. That means there is something called pseudo-hyponatremia. And so once we rule out pseudo-hyponatremia and we say this is a true hyponatremia, then we are looking into the tone of the, or the osmolality of the blood. And so we classify them as isosmolar, hyperosmolar, or hypoosmolar. And once we have said, so here what we're saying is if the electrolytes are low, then the osmolality should also be low in a pretty logical way, right? So if there's a hyponatremia, then osmolality should also be low, and that is what represents true hyponatremia. But we do have two conditions where the osmolality is normal or the osmolality is high, which technically should not be there, but we need to keep that in mind, rule it out before deal with a true hyponatremia, which is a hypoosmolar hyponatremia. And when we come to that, then we are looking at the volume status over here, whether it's a euvolumic, hypovolumic, or hypervolumic. So this basically gives you a overview of what we are talking about. So, and the causes, the cause of hyponatremia will typically go along with the understanding about what is the type of hyponatremia. Right. So now, just to remember some of the values you would be knowing. So normal osmolality is 280 by 300. Sometimes they call it as 295 also. So keep the osmolality in your mind. Okay, the way it is calculated is the formula. Sodium potassium is the potassium, as you saw, is a very small amount. So practically it's sodium, twice sodium glucose divided by 18, and BUN divided by 2.8. And so basically osmolality is about the total cations and total anions put together gives you the total osmolality. And we classify them as iso, hyper, or hypo using the normogram, whether it is less than 280 or more than 295 or 300. So the first step is to look at the osmolality. Now, a little word about the osmoles, which are the electrolytes which determines the osmolality. So we divide them as effective and ineffective osmoles. So effective osmoles are which stays within a compartment and don't move from one compartment to the others, right? That is what tonicity of the things. And so based on that, we have divided them into effective and non-effective. So effectives are sodium, glucose, mannitol. All these are impermeable to the membrane, stays within the same compartment unless there's an active movement or a energy-based movement from one to the other compartment. They are the one contributing to the tonicity. As compared to that, ethanol and urea, they move easily between two compartments and thereby do not contribute to the tonicity of it unless you have conditions where, say for example, if you're looking at urea, if there's a renal failure and it stays on, then it may contribute to some extent. So just have to remember that we have these effective and ineffective osmoles. So the first thing is isoosmolar hyponatremia. So keep it in your mind. Hyponatremia typically should be hypoosmolar, and isoosmolar and hyperosmolar we need to settle. Why should the osmolality be normal or increase in a patient with hyponatremia? If we have sorted that out, then we'll come to the main point. So if the osmolality is normal, that means this is a condition where we call it as pseudo hyponatremia, where you have hyponatremia with a normal serum osmolality and the patient is euvolemic. And other way of labeling this is where your calculated osmolality and the measured osmolality is more than 10. Normally it should be within 10. So this is other definition to say that if your calculated minus the measured osmolality is more than 10, then you are qualifying for this definition of pseudo hyponatremia. And the reasons why this happens is because of increased triglycerides and proteins. Anybody can explain why this has, what is this conditions and why, how does triglycerides and serum protein contribute to that?
Draws water into the cell, into the extracellular space. And so when you measure the sodium that you dilute from that, density is maintained by the osmotic effect of the protein.
So you mean to say there's more water in the vascular compartment because it draws? Anybody? So if you look at the water in a vascular space, that's about 95%. So 5% is because of the non-water component, right? And that is usually proteins, a little bit of fat and cholesterols. So when there's a hypertriglyceridemia on one side, or there's a hyperproteinemia, like in myelomas or Waldenström, so in that, what happens? This 5% space is increased to more than 5%, which is taking away the space of the water. Now, when we check for sodium, it's the flame photometry. It's just checking the amount of it. It's not really measuring the volume or the denominator. So because your water compartment has been reduced because of increase in this amount of either it's a triglycerides or plasma, the calculations now that you do is showing that there's a hyponatremia. So it's more of a there's no hyponatremia, there's no true hyponatremia. It's just that the calculation has gone off because of the way sodium is measured and your denominator has changed. So in that background, this appears to be hyponatremic. That's what we are measuring in the blood, but the sodium in that whole thing is still within the normal range. Right? So this is important for us to understand because based on this, we decide how we are going to look for the causes. So when you have a normal osmolality, there's a hyponatremia, then you should be thinking about one of these causes. Two are triglycerides and proteins are there, but you also have to remember that there are a number of drugs by different mechanisms can also cause that. So very important in the history is you have to take a whole detailed history of what are the drugs, what are the other treatment they have been taking on, right? The other situation comes is somebody has taken IVIG that can also increase your protein content in the vascular space, which will also give a false reading of sodium being low. The second is hyperosmolar hyponatremia. Now, technically, osmolality should not increase in a patient with hyponatremia if it is purely hyponatremia. So there's something that adds on the osmolality to the blood, which gives a hyperosmolar as much as the sodium that we are measuring is low. Again, the volume status would be volumic. Usually, there's a fluid shift from the intracellular space to the extracellular space. And usually the common reasons for these is either there's a high glucose level in the blood. Again, remember these are effective osmoles, right? So effective osmoles are, we talked about glucose being one of them, other things. During surgeries, TORP surgeries, they may put some things like glycine and other things can also contribute to those affecting osmoles. So when these osmoles goes up, your osmolality goes up, whereas the sodium as measured over there would be low. There is again a calculations. If you have a person who has come with very high sugars and has showing hyponatremia, there's a calculations how you can adjust the sodium as per to the level of the sugar levels over there. The formula is given there. You can use that and recalculated the calculated sodium. So this is what we are going to talk about is hypoosmolar hyponatremia. So that means there's a true hyponatremia, and because of that, the osmolality that you're measuring is less than 280. And using the same formulas, calculated versus measured is usually less than 10 as per that. So when you have these conditions, then we are looking at the volume status. You're looking at whether it's euvolumic, hypovolumic, or hypervolumic. And then what is the reason to further know what is the cause for hyponatremia in these cases? We are looking at whether it's a renal or a extrarenal loss of sodium. And so you're looking at the urine sodium and the urine osmolality to understand that, and that will go into the branching. So basically that's how it will be looking like. So on top you have got your hypoosmolar hyponatremia. You have three categories. You're looking at hypovolumic, euvolumic, and hypervolumic. And then you are looking at whether it's renal or extrarenal. And so urine sodium becomes important at this point of time to differentiate that. Now, if you look at, we'll look at each one of them. So if you look at a hypoosmolar hyponatremic, which is euvolumic, so the next step that we go is to look at whether sodium is being lost from the kidneys or being lost from elsewhere. So you just look at urine sodium. If it is more than 20, you are saying that the loss is from the kidneys. And the causes that comes under that is you're looking at syndrome of inappropriate ADH secretions, glucocorticoid deficiency, hypothyroidism, and some rare things like hereditary reset osmostat, or there are a number of drugs that you have to remember over here, right? So drug history becomes very important in any patients who are coming with hyponatremia. You need to have those list of drugs. There's a list of drugs that with. If the sodium is less than 20, then we have these three conditions. These are not so very common. Still have to keep it in mind. Psychogenic polydipsia, beer potomonia, or exercise-induced hypoosmolar hyponatremia. So these are how your algorithm will go. And among all of them, SAIDH is something that will commonly be seen. And so what are the things that we're looking at is that the ADH levels is the key thing that goes high over here, which causes increase in the total body water. And most of the time, hyponatremia is more about not sodium being less, but water being excess as compared to the sodium. And as we mentioned, urine sodium is lost over here. And hypouricemia is another features. And this is something that will help you differentiate between a euvolemic from a hypovolemic, and one of those conditions is cerebral salt wasting syndrome, and hypouricemia is something that can help you to differentiate between these. SADH, again, you have to remember it's a diagnosis of exclusions. You have to rule out certain conditions, and there are some criteria that is been given. So Swartz diagnostic criteria for SAIDH. Diagnostic criteria, they are supporting diagnostic criteria. There's a whole list over there. Key things to remember over here is what are the things that you need to rule out before you label it as SAIDH. And so those are some of the list of things that you have to go. So you are looking at the measured serum osmolality. We talked about clinical euvolemia, urine osmolality, and sodium that we talked about. You need to rule out, and that's something that we do commonly, and you would remember is ruling out hypothyroidism, ruling out Addison's in these conditions. Renal function should be normal, exclude other drugs that they may be taking, no hypokalemia, no acid-base disorder. So based on these criteria, these are the things that you have to keep it in mind. And on supporting diagnostic criteria, they're mentioning about uric acid, urine nitrogen, fractional sodium excretions more than 1%, failure to improve on worsening hyponatremia after point normal saline infusions, and improvement of hyponatremia with fluid restriction. So these are some of the criteria that has been given. So a number of things are there, but very broadly to remember, just remember how our algorithm falls through. The other thing, as I was mentioning, is something that is very closely you have to differentiate is between SIDH and cerebral salt wasting. Clinical, sometimes it will be difficult. As theoretically, SIDH is a euvolemic stage and cerebral salt wasting is a hypovolemic stage, but sometimes it may be very difficult to really differentiate the euvolemic and a hypovolemic. So you have to use various other parameters to differentiate between both of them. Right? And ADH level is something that helps, and then you have the uric acid also that helps over here. But again, you see the differences are pretty close. Urine volume, they're mentioned as normal or low, which is high in cerebral salt wasting syndrome. Urea may be high in cerebral salt wasting syndrome. So you could use some of those parameters to differentiate between SAIDH and cerebral salt wasting syndromes, these will be a little close differentiating features when you're looking at it. Now, some of the common cause of SAIDH, malignancies, pulmonary disease, CNS disease from infections to neurodegenerative diseases, post-operative you can have. Now, some of the drugs that has been classified as drugs that potentiate ADH actions, NSAIDs, fibric acid derivatives, certain drugs which stimulate ADH, these are seen in narcotics, barbiturates, chemotherapies, and anticonvulsants. There are some drugs which has both the mechanisms, oral sulfonylureas and thiazide diuretics. So again, taking the history, getting to know the background of the condition is also important for us to understand. So on one side, as you are managing your sodium, you are keeping in your mind to look for these can also be triggers for you to think about the primary diagnosis that a patient may be having, right? So now we're coming to the hypovolemic, hypoosmolar hyponatremia, where actually the total body sodium is low. Again, we are trying to see hypovolemia. Is it because of renal loss or non-renal loss? We are using the same criteria, urine sodium and urine osmolarity. And over here, we find the cerebral salt wasting comes. So as I mentioned, this is a hypovolemic state. And other causes are diuretics, mineralocorticoid deficiency, salt losing nephropathies, various chronic pyelonephritis, interstitial nephritis, renal tubular acidosis, and ketonuria has also come up over here. The non-renal causes are GI losses, vomiting, diarrhea, skin losses through burns and fevers, or third space sequestrations like pancreatitis, peritonitis. So these will be your volemic, hypovolemic causes for hyponatremia. All these are something to be kept in mind, not very common, but we do see these conditions and you have to keep in your mind whenever you're evaluating a patient with hyponatremia. The third conditions is the hypervolemic, and where yours renal and non-renal, again, we are trying to differentiate that. Hypervolemic, where the fluid is high, either it has to be one of the failures. So non-renal are congestive heart failure, cirrhosis, nephrotic syndrome, whereas renal losses are acute and chronic renal failure. Again, that is being differentiated using your urine sodium. So this is a little busy slide, but this kind of summarizes the whole thing that we are looking at approach. The starting point is a plasma osmolarity. And as we mentioned, we are looking at hypoosmolar or isoosmolar. We went through that. And if it is a hypotonic hyponatremia, looking at the volume. And based on that, the various causes that we just discussed. So how do we manage? Now, a lot of things that has happened over a period of time and a lot of questions you may have. So finally, how do we manage? Okay, so we'll try to put things together as much as we can. So understanding hyponatremia, keeping in mind that is primarily there an increase in water intake, which dilutes our things, impaired water excretions. So water is retained, dilutes the sodium, or there is a persistent release of ADH. So very broadly, we are putting under these three headings. Now, what are the things that we have to consider while we manage hyponatremia? So as I said, hyponatremia is very critical. You don't manage it, you are into problems. You manage it inappropriately, you are into problems. But sodium is not the issue in this patient. It is the underlying disease that we are finally trying to treat while we are buying time, stabilizing the patients, keeping him alive till we get to the diagnosis and manage the major things. So what are the things that we need to keep it in mind as we manage hyponatremia? Number one is the duration, whether it's acute or chronic. That's something that we need to keep it in mind. The cutoff line is 48 hours. Anything less than 48 hours is acute, more than 48 hours is chronic. We are looking at the severity of hyponatremia. 135 to 130 is mild, 130 to 120 is moderate, and less than 120 is severe. So more severe, you need to give it importance. Third is symptoms. Now, symptom is more related to the rate of development of hyponatremia rather than the severity of hyponatremia. So if it is a chronic hyponatremia, which has chronically went down, is presenting you with very less than 120, but is asymptomatic, is quite possible, right? But in acute, what happens? So just have to understand, if there's an acute drop in the sodium, it completely disturbs your, what you are more concerned about is the cerebral symptoms and all. So causing edema, and having symptoms, CNS symptoms, are seen more with acute. So even though fall may not be as much, but if the patient is symptomatic, the key is you need to reverse it as fast as possible, right? If it has happened slowly, be careful. The body is at homeostasis if the patient is asymptomatic. Suddenly disturbing it will cause more problem. So chronic you have to go very carefully, gradually, slowly, with a lot of monitoring and following up. But acute, since the pathogenesis is just about happening, it's very important. If you have to salvage the patients, they will be more symptomatic. They can go down pretty fast. Herniations, seizures, cerebral edema, all those things can happen. So that has to be aggressively reversed. You have to go pretty fast over there. So just keeping those principles in mind. The fourth is if a person already has some underlying intracranial pathology, trauma, hemorrhage, or any other intracranial pathology, also needs to be kept in mind as you are managing it. So the key three things are: is it acute or chronic? What is the level of hyponatremia? And is it symptomatic? All these three things are very clear parameters which will tell you how. So if these three things are there, we have to correct the sodium, right? What to use, from oral salt to parenteral treatment, from normal saline to hypertonic saline to other drugs. You have those variety of things that you have to choose. So the key thing is over here is which one to choose and how rapidly we need to correct. So those are the two things that you really have to know as you manage the patients, right? So acute, as we said, less than 48 hours. Usually it is seen in patients where you have a post-op IV fluids like in TRP, water intoxications. Among psychogenic water intoxication, competitive runners or user of ecstasies. These are more symptomatic because they will have edemas and seizures, and these requires aggressive treatment. So just keep all these things in mind. You don't have to worry if the sodium has dropped suddenly. You can bring it suddenly up over there. It's when you are trying to correct the chronic ones more aggressively, you can have problems there. But in acute, you won't have any problems. So just have to keep all these principles right in our mind, that if there's an acute drop within 48 hours, they are symptomatic and they need to be treated aggressively. In chronic, any hyponatremia more than 48 hours, there will be less chance of symptoms because body tries to adjust to those changes. Treatment has to be slow and cautious. There's a greater risk of complications when you're managing chronics, and there's a greater need for. So these are two things you have to keep it in mind. One, that you treat them slowly, cautiously. Second is you have to monitor them very closely, right? So chronic is more. So there are other things that is very important in the chronic hyponatremia as compared to the severity we just talked about. So mild, moderate, and severe. Just have to remember the values less than 120. Severe, something that you have to be worried about, but the levels has to be seen in the context of the duration, right? So don't look at the levels 120 and you start panicking and start doing it. No, it has to be looked into the context of how it has developed, how fast it has developed. Symptoms, as we said, it's based on the duration. Patients can be asymptomatic and have mild to moderate symptoms, or it could have severe symptoms. The usual symptoms of mild to moderates are generally kind of a non-specific symptoms: headache, fatigue, lethargy, nausea, vomiting, dizziness, gait disturbances, forgetfulness, confusions, muscle cramps. So a whole lot of non-specific symptoms will be from mild to moderate. What you are really looking for is the patient having seizures, and you look at the statistics. Acute hyponatremia, seizures are seen almost in 30%, and chronic less than 7%. Obtundation, coma, respiratory arrest are the symptoms that you're looking at. If these symptoms are there, you need to act a little bit more fast and aggressive. Indications of admissions, that's the other things. You come to our OPD, the blood results come in, you show the sodium, and you're wondering, should I admit it or should I manage it from the OPD basis? Any acute hyponatremia has to be admitted. Severe hyponatremia less than 120 has to be admitted. Anybody with symptoms has to be admitted. So these are the three things that we lay down right in the beginning, are the key things that you have to see as you manage it. Acute, severe, and symptomatic, they have to be getting. So never ever try to manage them on OPD basis. What are the goals of therapy? Goals of therapy is to prevent further decline in serum sodium concentration. So person comes with a particular sodium, just have to make sure it doesn't go down, and it will go down if you are choosing the right treatment methodology. So it's very important to know. So the minimum that we are doing is to make sure that it doesn't go down further, to decrease intracranial tension in patients' risk for brain herniation. Second is they would develop cerebral edema before they herniate and all. You have to keep that in mind to relieve symptoms of hyponatremia. And fourth is to avoid excessive correction of hyponatremia in patient at risk for osmotic demyelination syndrome. So we'll come to that. So we know the complications of mistreatment, and so that's another goal that we should not make sure that nobody should go into osmotic demyelinations because of the choice of a treatment, right? So even before we treat, we should know which are the patients who are at a high risk for osmotic demyelinations. We'll be talking about it. Now, while we are managing, there are some general measures that all hyponatremia patients should have. And those are, first, identify medications. You can see there are drugs in almost different categories, and each of them can contribute towards hyponatremia. So make sure you have taken a good drug history and look whether any of those drugs can contribute to hyponatremia. If it is so, first thing is stop that medicines. Okay, stopping means if it is very essential medicines, you should have alternatives for that. So look for medications, discontinue that, reduce electrolyte free water. Make sure your fluid advice should be very clear. Restrict fluid intake generally, eliminate hypertonic intravenous fluids, increase dietary salt intake, identify and treat cause of hyponatremia. That means adrenal insufficiency, neuroendocrine tumors, any of the underlying conditions which is there. So these are the general measures that you do for all patients of hyponatremia as you manage hyponatremia, as you identify and manage the underlying disease. So these are some risk factors for osmotic demyelination. So who are the people who are at a high risk? Who are the people at a low risk? You need to know right from the beginning, and you need to be very careful how you're going to make your plan for management. So high risk are patients who have got sodium levels of less than 105, patients with hypokalemia, alcoholism, malnutrition, liver disease, hypophosphatemia. If the patient has any one of these, be very careful. These are the patients who are most likely to go into osmotic demyelination. So you should take utmost care as you make your plans. Patients who are at a low risk are those patients of acute hyponatremia due to a marked increase in water intake, marathon runners, primary polydipsia, users of ecstasies. These are causes for acute hyponatremia, which are usually reversible. So you're looking at reversibilities. The ones which are chronic are generally resistant to quick reversibility. These, these are the causes. You take care of it, they quickly reverse. These are the patients with lowest risk of osmotic demyelination. So have to keep in your mind where you need to be more careful about. So now we are looking at management of acute hyponatremia within the first 6 hours, right? So what is important is what should be the rate of corrections. Now, you all would have learned some formulas, calculating sodium deficit, treating and all those things have now been found not really predicts well. So here we are looking at what do we do in the first 6 hours, which is very important for the patients, right? So if a patient who's coming with acute hyponatremia, during the first 6 hours, the rate of corrections for a severe hyponatremia should be a rise of 4 to 6. Previously, 10 to 12 milliequivalents rise were what people used to talk about, but then They have found that more than 10 to 12, there's a very high risk for osmotic demyelinations. Less than 4 is something that doesn't really help. So 4 to 6, going maximum till 8 is what the goals of daily corrections that has been put in, right? If it is a severe hyponatremia, you correct in you target a rise of sodium by 4 to 6 milliequivalents in the first 24 hours. But if the patient is symptomatic, then that rise should happen within the first 6 hours. So your target is 4 to 6 milliequivalent per day, right? As a bottom line, you can go maximum up till 8, but not more than 8, right? If it is severe, target for 24 hours. If they are symptomatic, target for that corrections within the first 6 hours. Okay, so that's the first thing that we are looking at. So how do we correct that? So if it is an asymptomatic acute hyponatremia, you can give them a 50 ml bolus with 3% normal saline. So you'll realize most of our treatment is using hypertonic normal saline. I mean, there's a major concern with isotonic even in fluid loss, right? Because of all the hormonal changes. When you do it, it takes a lag period. So most of the time, the treatment is with hypertonic saline. If it is asymptomatic, start off with 50 ml boluses. Most of it is boluses. The infusion rates and all those things are a little fuzzy. So what they have found is these are all safe based on various trials. Don't have to worry about it. So asymptomatic acute hyponatremia, 50 ml of bolus of hypertonic saline, 3% saline. If the patient is symptomatic, then you can give them 100 ml of 3%. Again, it's a bolus. Bolus means you're giving it over 10 minutes, right? Give them one bolus. If the symptom subsides, good enough. If it doesn't subside, you can repeat it 2 more times. So maximum you are giving them 3 boluses of 100 ml of 3% hypertonic saline. So the goal is to raise the serum sodium by around 4 to 6. We just talked about it. Here you can go over few hours. So you can go even as fast as within few hours. And these are all kind of looked into and found safer. So there's no issues to be worried about, right? Do not use mannitol or Vaptans because of these 2 reasons. Mannitols, I mean, especially if you are thinking about cerebral edema, wants to give, these are nephrotoxic, and Vaptan has a very slow onset of action, so it doesn't really work fast. So if you want to correct sodium fast, these are the things that you have to go. In asymptomatic 50 ml, in symptomatic 100 ml, you can repeat max up till total of 3 times. Give it as a bolus over 10 minutes. Keep watching for symptoms and keep monitoring the sodiums. Chronic hyponatremia in the first 6 hours, how do we go? If it is a mild hyponatremia, that is 130, 134, you just go by general measures that we just talked about it. General measures: discontinue the offending drugs, restrict further intake of water, reverse any identifiable cause. If somebody you know this was the cause for hyponatremia, take care of that. Don't give any hypotonic intravenous. If there's anybody who's on hypotonic intravenous infusion, stop it. So in a mild chronic hyponatremia, nothing, just the general measures that you do and monitor that person. If it is a moderate to severe hyponatremia, less than 130, you are looking at it whether it's asymptomatic, symptomatic, or any pre-existing intracranial pathology. These are the ones that is going to determine whether you are going to give a correction or you wait conservatively, right? If a person is symptomatic and has some underlying race pathology, you need to correct it the same way that we just talked about previously. If there are severe symptoms or known intracranial pathology, again, you'll see the recommendation is the same thing, right? You're giving 100 ml of boluses of 3% saline boluses over 10 minutes, and you can repeat 2 more times, a total of 3 times. Same recommendations. All that you're doing is you're choosing whom to give and where you go, right? The only doses that they have different is 100 ml, where they are symptomatic, severe, whereas asymptomatic, you can give them 50 ml. So there's a little other alternative recommendations by the European organizations of giving 150 ml of 3% over 10 minutes, and you can repeat after 20 minutes, second bolus. So the other one is 100, 100, 100. This is 150, 150 spread out between 20 minutes. So you are essentially giving about 300 ml of 3% solution, sorry, 3% saline, and you're giving as a bolus. So the whole idea of bolus is the amount and how many times you can repeat it is what they are looking at, and what are the symptoms that is determining is what we are looking at over here. Now, patients with severe hyponatremia that is less than 120, here the recommendation is IV intravenous 3% saline at the rate of 15 to 30 ml per hour administered via peripheral line. We use 3% saline rather than normal saline in patients with and without suspected hypovolemia. Now, this again, what they, you don't need to go for a central line for these replacement. You will be wasting time trying to get a central line access. Peripheral line is as good what the study shows, right? So have a peripheral line. You can put the 3% saline at the rate of 15 to 30 ml per hour administered through it, and you can, and so that's the recommendation that they say. An alternative option is to give 1 ml per kg, maximum 100 ml boluses of 3% saline intravenously every 6 hours with dose modification as needed. So in a patient who has got a severe hyponatremia, this is what their recommendations are that you are giving them. So previously we were giving them 100 ml 3% saline boluses over 10 minutes, repeating maximum 3 times. Here you are giving it a little bit more continuously over a period of time. Either you give it in this way, or you can give it every 6 hourly in the other dose. And these are the group where some patients may require desmopressin to prevent over rapid correction. So this is the management of chronic hyponatremia who has a severe hyponatremia less than 120. For desmopressin, the indications are patient with reversible cause of hyponatremia, patients who are likely to develop a water diuresis during the course of therapy, and patients who are at a high risk of developing osmotic demyelination. So desmopressin you may want to choose in these 3 settings. Reversible hyponatremia may develop water diuresis initially, and those who are a high risk for developing ODS, you are giving this to prevent osmotic demyelination. And the usual dose is 1 to 2 microgram. You can give it IV or subcutaneously, 6 to 8 hourly. You give till the sodium level reaches 125, and this can be given proactively at the beginning of the therapy with 3% normal saline, that is before any treatment is given to correct the hyponatremia. So that's the other thing that we have to keep it in mind as we treat them with desmopressin. Now, these management acute hyponatremia, these were things that was given before, but most guidelines says that most of these do not really represents the deficit, and as you keep recalculating as you treat it, doesn't really predict. So most of the guidelines do not really talk about all the calculations. Other treatment, loop diuretics in patients with high urine cation concentrations. The urine serum cation ratio, if it is greater than 1, there's a role of loop diuretics. Oral salt in patients with SIDH. 1 gram oral salt is almost equivalent to 30 ml of 3% saline, and 9 gram of oral salt is almost equivalent to 1 liter of normal saline. So these are the oral considerations. So if a patient chronic hyponatremia, SAIDH is the diagnosis, and you want to manage them OP wise, you can give them oral salts, and it's supposed to be quite effective. If they're symptomatic, if they are severe hyponatremia, then they would be requiring admissions for that. So, any questions so far? How have you all been managing? Yes, Tony.
Thiazide induced to severe hyponatremia, sir. If we stop thiazide and shall we wait, sir, or shall we give 3% nascent bolus?
So, so here there are two things we're looking at. One is you're looking at the sodium management, right? So you're looking at how low the sodium is, and then whether it's an acute or not. So severity of sodium, the level of sodium, the acuteness of what it is, and whether it's symptomatic. So you look at those things and you plan your sodium correction management. And then the second part is your management of the underlying condition. So if the patient is on thiazide diuretic, needs thiazide, needs some form of management for it, that is for heart failure and all, that's the other management that you have to use your kind of a decision as to what are my other options that I can give it over there. Right. So, but the management of hyponatremia, if you're just looking at hyponatremia, here we are looking at, we know that this is the cause for hyponatremia. And so the first thing is to see what is an alternative for that drug in this patient. As you take care of it, the sodium will start correcting over there. And then based on all those three parameters, you're deciding whether I'm looking at it conservatively or do I need to give him something to correct it. So if you have these two things, it's very difficult to make a decision. How am I going and what am I going to choose in that management?
Yes. On the first time, incidentally we diagnosed hyponatremia with the lab. How do we know if it's acute or not?
So yeah, so acute means if you know obviously the person had something before. If it is not, then you will presume that most likely it's chronic. The second thing is you're looking at symptoms also, because as we said over here, that most of the symptomatic are acute. So it's an indirect interpretation. So if the patient is symptomatic with low and you additionally get some history which gives you the reason why they develop hyponatremia, you're labeling it as an acute. So again, it's all about a clinical impressions that you make based on whatever history that you have, the presentation. But most likely, most of them, if they are incidentally detected hyponatremia, may be a chronic one. And if they're asymptomatic also and there's no other acute causes that you can find out, then you would kind of presumptively label it as a chronic and follow the same steps. So your main focus is to find out the underlying cause, make sure that this hyponatremia is stable and nothing should go wrong. Either if you don't treat what you should treat, or if you over treat something, either of those things can be fallen. Just trying to reinforce that so that you can make decisions based on that.
Is there any indication to monitor sodium after each bolus or how do we go?
Yeah, so in a very sick patients, they should be in ICU as per guidelines. They should monitor sodium hourly. In a very sick patients, 4 to 6 hourly for relatively less sick patients. They should not be in the general ward. Those are the ideally as everything is falling into place, right? So I mean, it's 10 minutes, 10 minutes, 10 minutes. It's much before the 6 hours. So what we're saying is you're giving it as a bolus. If it is a symptomatic, the symptom should subside. So you keep repeating maximum up till three times till the system subsides. So you are virtually doing it continuously. So you're not waiting 6 hours. 6 hours is quite long back. But those are the acute management. So all the management that they're talking about is how do I manage sodium so my discernment of deciding whether to treat and what to treat. Those are the two things that you are making, whether it's the 6 hours or 24 hours. And at the same time, you are trying to work him up to find out the underlying cause. Yes. Good. So Vaptans, reading about it, the indication is very small. It's still not very well established. Cost is very high, side effects are there, and so in a very resistant hyponatremia, not responding and fitting in, there are some contraindications for those. So as long as all those things fit in, maybe a very small subset of patients where you may give it. Not really widely strongly prescribed. No. Go ahead.
So a patient with like hypovolemic hyponatremia, very like often it happens that we get heart failures who also have say a cardiorenal or something at presentation, and we don't know if there is a component of renal loss also. So those patients we often label them as mixed etiology of hyponatremia. If this patient were to, in asymptomatic patients, usually we try to diagnose with some their improving the serum sodium concentration. But if you are a symptomatic patient, you go ahead and give them some hypertonic saline, which will not.
So again, it depends on your symptoms. So is he symptomatic and what is his level of sodium? So if it is symptomatic and his sodium levels are low, I mean, if you have less than 120 with symptomatic, less than 120, you can kind of still wait on and try other things. If it is symptomatic, you don't have any option. You don't have any options here. Either he dies of heart failure or dies of hyponatremia. If he's symptomatic, means you don't have any options but to immediately reverse it. Only good thing is that if it is a one, there's a dilutional, and other is the patient is also on diuretics, reversibilities are there. You can acutely raise up the sodium without any issues. That's one thing, that your treatment is not going to cause more damage, at least CNS wise. Cardiac wise, there's always a concern whether I'll push them more into failure because we're giving a sodium load over there. But that's what medicine is all about. I mean, as I said, severe hyponatremia 120, you can wait and decide what is the best. But if he's, I mean, you don't have any options. You have to go ahead.
So one more question is serum calcium ratio and urine calcium ratio is
Yeah, they have given the calculations. These are. I mean, there are lots of things in hyponatremia. Sunrise, lot of algorithms are based on ADH levels. Also, some people use ADH to differentiate many things, but we're just trying to use the basic ones over here to have a general approach for majority. Majority will be a hypoosmolar hyponatremia, which is a true hyponatremia, and among them, most of them would be SAIDH, and there it is pushing it look. But as you rightly said, we do see all these patients, heart failure, cirrhotics, nephrotics, they are dilutional hyponatremia. So here the question, everything is driven by these 2 points, that is there an indication for treatment, and then what treatment I'm going to choose. So I think if we are just going home with these 2 things, I think you have got that parameter done. But in medicine, it's not enough, because your patients are having multiple cofactors. If I give this, that will happen. If I give this, this will happen. If I don't give, so that's a bedside decisions that we all keep making. But at least if you're looking at what is black and white that I need to do, and this is clear-cut indications that I have to treat, is what we are trying to draw over here. So here, at the nutshell of the everything is that which hyponatremia should I treat, and what is my treatment algorithm for these patients. What can I give it? How fast can I give it? How many times can I give it? How many? What all things I have to monitor is what very in a very what should I say, in a very squeezed way we are looking only at hyponatremia. But you see, your patients will have multiple other things that you have to walk a tightrope and try to make a decision. So the best evidence that I have tried to collect and put together as per the guidelines are just these, that keep it in mind, the severity and symptomatic, to decide whether this needs treatment, and if need treatment, they have very clearly said the things that you have to use and boluses and how many times you have got to use. But there's a whole gamut of underlying conditions that you have to keep it in mind as you make decisions to give it. So on a bedside, you may err this way or that way, and that's the clinical decisions that you have to make. Go ahead, Tony.
So in a severe hypovolemic hyponatremia like chronic malaria, their volume is very much depleted. In that case, we need to correct NS because NS, if we give NS, then we can expect the sodium to come out. In that case also, do we need to follow this 3% saline, sir, or
if it is a severe symptomatic hyponatremia, that is the first thing you give, and then additionally you add on the volume expansion. So when you look at all these hormones and all, if you just give them straight away, that's what we were taught, that it's a volume loss, give them normal saline. But when you give them normal saline, these ADH and other things, it takes a lag before it picks up. You can cause further deterioration. So isotonic saline in a patient which is severe and symptomatic is completely no. So first thing is get the sodium right. The patient may not die because of hypovolemia unless he's in shock and all, that's a different thing. But first correct that, and then slowly, as that time permits, keep adding on the fluid to that. But that's the key thing is the treatment is hypertonic saline. So that is something that comes up, especially if a person doesn't have a severe hyponatremia, has come with obvious fluid loss and all, you give a normal saline, no issues over there. But when you're talking about a severe, that means you see that decisions may tip off that sodium from going from wherever it is. The first, make sure your sodium doesn't go below. So going by that, if it is already low, be careful what you're choosing. So here we are only looking at sodium first, right? So make sure sodium is taken care, and then the underlying. So here the underlying is he has come with a volume loss, vomiting, diarrhea, and all that fluid has to be replaced. That is no question about it. But if the sodium is critically low and is symptomatic, your treatment and your choice is hypertonic saline. Okay. So it's not that you're only treating with hypertonic saline, the fluid has to kick in, but later on, once your sodium is in the safer levels. Because the worry is that if you choose normal saline in that, you will cause it to go and you don't want CNS complications coming up. So very clearly for isotonic, they have given a whole list of things. They have argued that giving all these things in each of the situations can be counterproductive. So you should be very clear that you are choosing the choice of the solution at that point of time to correct the sodium. Once sodium is okay in the safer levels, then you go in for the regular management. Okay, any other things? Any other thoughts, any other new wisdom anybody has? What are you all following? Hyponatremia and the words? Sorry?
based on the volume set?
Based on the volume settings. So, what are you all choosing most of the time?
It's always I told you, after this class I will start. But
Boluses you don't give.
we didn't, yes, sir, we have never given bolus. Always, even if we are starting in a severe, who somebody having seizure, hyponatremia and seizure, there also we are giving 15 ml per hour. Increase only.
Not patient who was having severe.
Yeah, so now you know where to give bolus. I mean, please don't go home saying that everybody should get 3% bolus. No, you have very clear-cut indications where you give bolus, right? So please don't go home with the idea that any hyponatremia, we start giving them 3% bolus. 3% bolus is safe. That's one thing, because many times we are a little concerned about it. It is safe, but the indication of as a bolus is very clear. So when it falls, please go ahead and do it. If not, you have your regular things. I mean, after that, there's no very hard and fast what you should do and go. Do the general things first. If except for a hypovolemic, fluid restrictions, oral salt, monitor them, look into all the other parameters. As long as the sodium is in a safer zone, all those things are fine. Hypovolemia, sodium not bad, not symptomatic, normal saline, all those things are perfectly fine. But here, the critical thing is all that you have to keep it in mind. You should not miss the severe hyponatremia and a symptomatic hyponatremia. These two are very critical. Don't make mistakes in that, because you yourself will feel bad because of something if something happens to the patient. So I mean, I'm just drawing the boundaries. Beyond this is definitely that. Otherwise, rest of those recommendations are a little plus minus. It's okay, doesn't matter. But be very clear. Ask yourself that question: is this patient requires a quick correction, right? And if it is so, then what am I going to choose? So if they fall within the criteria for choice, you should give them. Don't hesitate giving them 3% with the boluses. Absolutely nothing to worry about that. But you should be sure, is this patient having indications for them? So that's what I wanted. I mean, to try to repeat it through virtually all the conditions. You are seeing the same thing they are talking about. So 3% saline, 100 ml, maximum 3 times. But the indication should be clear. If that is there, you can. This is pretty well established now. This whole thing has also evolved over a long period of time. So this is what the current consensus is. So just follow that, and you should be fine. And I think some of you all have already used it. And I think once you do it, I think you'll be confident.
So one big thing is actually the staff don't agree most of the time, especially this giving on a peripheral line. We do it very regularly, give on a peripheral line, give a higher bolus. They'll absolutely refuse saying either put a central line, anything over 10, sometimes they'll say 10 ml per hour also we don't accept. We've tried talking, because depending on the what we can give, some what we even give boluses and get away. Other words will block you there and say more than 10 ml we will not give. Even if they don't agree.
Up to date, very categorically, very clearly, almost underline says between peripheral line and between boluses and infusions. Very, very outrightly and very clearly writes down. So I think we have an evidence. I'm sure we will go through a little time of saying, but let us know if somebody is not agreeing and all. We can have a who is opposing the nurses and all. Yeah. So we'll have a session for. We'll have one session on hyponatremia for all nursing stuff, all our medicine. No, we need to do it because they also need to be updated. No, I mean, they are also being good. They are being helpful. They may say these are first years and all. These guys will muck up and all. Who gave them an idea to give boluses on? They may genuinely feel that they're helping you and the patient. So that's okay. Now that we know it, we can always have a gentle CNE with them and tell them what are the recent updates. They would be happy. I mean, unless they are unhappy that central line you have to put peripheral line, we have to put, so our work is increasing. So sometimes some other calculation can come in. But I'm sure we should move. We should take the nurses along with us, and if need be, if you feel that's a very strong reasons, we can have a sessions with them. That's absolutely no issues. But good you told us that, because I think at all levels we should move. They should also move alongside with us, and it wouldn't take much time. Just one sessions and clarifications will put all the systems in place. Good. Thanks so much.